Order. I will call Esther McVeigh. Can members please vacate the chamber quickly and quietly? Thank you. To move the motion, and I will then call the Minister to respond. I remind other members that they may only make a speech with prior permission from the member in charge of the debate and the Minister. There will not be an opportunity for the member in charge to wind up, as is the convention for 30-minute debates. Order, order. Esther McVeigh to move the motion.
I beg to move that this House has considered funding for GP practices in rural areas. Thank you, Chair, and I'm pleased to have the opportunity to talk today about this important topic. Statistics show that as of 2024, 17% of England's population live in rural areas, equating to 9.6 million people. And for these communities, accessing healthcare can be challenging. These challenges are well known. Rural GP practices serve elderly and often isolated populations, tasked with delivering complex care to a large and often sparse geographical areas. These demands have long been accounted for in our funding formula for GPs through the Carr-Hill formula. The model was introduced in 2004 and designed to ensure GP funding reflected the variations in workload and local population characteristics that exist, including a measure of rurality. That is, I will indeed.
I thank the Honourable Lady for giving way. Shurston in the South Cotswolds is in imminent danger of losing its surgery. Enormous local strength of feeling, 2,850 signatures out of 3,000 patients. By definition, as the Honourable Lady has mentioned, people who need doctor surgeries tend to be elderly, ill, or parents with small children. So does the Right Honourable Lady agree with me that the NHS should be prioritising provision of GP surgeries for small rural communities like Shurston?
The Honourable Lady raises a very relevant point, and I agree with her wholeheartedly, because I'm seeing lots of areas in my constituency who can't get to a GP and are just bereft of a GP surgery. So we're talking about the measure of rurality, and we've had that until now. For this government has instructed the National Institute for Health and Care Research to review the funding model and examine how working class areas could benefit under a new model based on deprivation rather than workload. I will indeed.
Well, can I congratulate the Honourable Lady for tapping for the subject matter she brings to Westminster Hall for consideration. We're always glad, I'm always glad to come along and support the Honourable Lady, because she does great debates and very, very applicable ones. As a resident of a rural area, the pressure that my local GPs are under has to be seen to be relieved. Only 3 practices covering all of the Irish Peninsula and a growing population. Does the Honourable Lady not agree that funding must be available to give surgeries, the potential to have physio rooms, nutrition advice and perhaps even a pharmacy that can provide first-stop medical advice, and to have the facilities like this will cost, and these clearly need to be met by government because there will be savings in the long term?
It's always good to have my honourable friend, and I will say friend, intervene on me, and he makes very good points. And I think it's also important that a local GP chooses and can see what their local constituents need and require and what is best for their health and their health outcome. So talking about this new model based on deprivation rather than workload, I will say the move to that at best is an act of ignorance and fails to acknowledge the significant challenges of running GP practices in rural areas, and at worst it represents yet another example of Labour's assault on rural life. Measuring pressures on GPs solely through the lens of deprivation would ignore the complex and distinct demands faced by rural practices. Rural communities have older populations. In 2019, the House of Lords Select Committee on the Rural Economy found that the average age in rural areas was almost 6 years higher than in urban areas, and a quarter of the rural population was over the age of 65. I will indeed.
Sir Prinsley.
I'm grateful to her for bringing this debate, which is very, very important. So Dr. Richard West, MBE, and Dr. Daniel James, general practitioners in Woolpit in Suffolk, in my constituency, have been awarded the Royal College of General Practitioners East Anglia Faculty Prize this year in recognition for sustained contribution to rural mental health and community-focused general practice. Does she agree with me that we must do all we can to look after the mental health of the rural population, particularly the isolated farm workers?
The honourable member raises a very good point indeed there, and I'd also like to congratulate his constituents. And the pressure that I know the farming community is under, and the impact the family farm tax, I know, has had on the rural community and farmers and their mental health has been significant. Life expectancy is also longer in rural areas, placing greater demands on GP practices. Statistics published by the Department for Environment, Food and Rural Affairs suggest that of people born in mainly rural areas in 2018 to 2020, they were expected to live 2.5 years longer than people born in urban areas. Older populations place greater demands on GP surgeries, presenting with complex healthcare needs and higher levels of chronic illness and frailty. The Rural Services Network analysis shows that GP registered patients over the age of 75 account for 11% of rural GP patients compared to just 7.5% in urban settings.
Will my honourable friend give way?
I will indeed.
I thank my honourable friend for giving way and my constituency neighbour, and she is making a wonderful speech. I wondered whether she was going to, in her speech, come on at any point to the pressures of house building. There's a huge pressure for new homes, and many of our rural areas are already struggling with insufficient infrastructure. I'm working with our GP in Hambridge, where their site is now too small and not fit for purpose with the larger population that they now have. And I wondered whether she agreed with me that as pressure is put on constituencies like ours in Cheshire for more homes, it's vital that existing residents have access to GPs that are in suitable premises, fit for the numbers and the older population that are often using them.
I want to thank my honourable friend and neighbour for raising that point, and she is absolutely right. The number of new homes that are going to be built in rural areas, putting excess and more pressure on the demands of the GP surgeries is significant. And without new GP practices, I'm not really sure where our residents are going to go when they need a doctor and when they need to see somebody about their health. I will indeed give way.
Thank the Right Honourable Lady for giving way, and on a similar vein to the previous intervention, 1 in 5 GP buildings predate the NHS itself, which is a quite staggering fact, and over a third of GPs say their premises are no longer fit for purpose. So in places like West Dorset, outdated buildings are struggling to deal with the current population, let alone the projected future growth as a result of house building. And yet fewer than a third of practices that applied for capital funding last year were granted. So I wonder whether or not the Right Honourable Member agrees that GP estate funding must also be expanded to help rural areas deal with the increased population size.
I do agree with the honourable member, and I will come to a set of my surgeries that are indeed in Victorian buildings spread across 4 and need to be brought together, modernised, and that's in Knutsford in my constituency. So I know that there will be many other places like that across the country, and the honourable member raises a very, very valid and pertinent point. We know that GP services in rural communities are spread across a large geographical area, and there are many elderly residents in Tatton who live alone. While this independence is cherished, travelling long distances to access healthcare is more difficult. Public transport is often limited or non-existent. And while community transport schemes do exist in Tatton, they cannot always accommodate short notice or urgent medical needs. Elderly residents often do not drive, so they are left reliant on costly taxis or GP staff taking the time to travel to a patient's home, placing additional pressures on already stretched services. in Lostock-Raylan, despite a population of around 2,800 people, there is no GP practice, forcing patients to make a lengthy journey to Northwich, and without a direct bus service, many are left to rely on taxis to make their appointment. For these communities, recruiting and retaining staff becomes both more difficult and more expensive too. The Rural Services Network reports that 59% of hard-to-recruit GP specialty training posts are located in rural areas. There is less access to specialists and consultants, making their services more expensive. Community services and provision are sparser in rural areas too, so pharmacies, which help relieve pressure on GPs in urban areas, are not as common in rural areas. And when I secured this debate, I was contacted by the Dispensing Doctors Association, who provide an essential role in dispensing medicines to patients who live more than 1.6 kilometres from a pharmacy. They deliver to around 10 million patients across England, but are facing increasing challenges due to their reliance on manual delivery. In addition, while urban pharmacies move ahead with digital efficiency, rural farmers often struggle to keep pace because broadband coverage is often unreliable, rendering remote consultations near impossible and service delivery more difficult. The benefits that come with the digitisation of healthcare are well understood across this House, but they rely entirely on having the right infrastructure in place. And without connectivity, rural practices are simply unable to access or benefit from government investment in this area. And there's lots of people from rural areas here and will know how unreliable our broadband infrastructure is. In 2022, the All-Party Parliamentary Group on Rural Health and Care published an inquiry into healthcare in rural areas, concluding that rurality and infrastructure must be redefined to allow a better understanding of how it impinges on health outcomes. But no progress has been made on achieving this. To remove the rurality measure of GPs funding entirely would be a step backwards in understanding how settings impact the ability of GPs to provide healthcare. Madam Chair, in terms of this review of funding, of the funding model, there is also little transparency around who is exactly going to be consulted on this review. In answer to a written parliamentary question, the government confirmed the review will draw on a range of evidence and advice from experts, such as the Advisory Committee on Resource Allocation and the MBA GP Committee. But there is little information beyond this. And I know there are GPs in Tatton who are keen to contribute, but as of yet have not been able to. I will indeed. I'm keeping my eye on the time.
I'm very grateful. It is obvious that there is a problem funding the recruitment of additional GP partners in rural surgeries. Would she agree with me that we should think carefully about how the partnership model itself might be improved?
The Honourable Member raises another good question, and that is something I think we can ask the Minister to look into as well. Now, the logical conclusion of this not having GPs from rural areas take part in this review is that the government do not want to listen to them, intent on rewriting the formula without acknowledging the realities of delivering rural healthcare. A broad brush measure, such as deprivation, cannot take into consideration the very close link between the ability to deliver healthcare and the rural or urban settings in which they exist. It comes as little surprise whether it is selling off our family farms or introducing a devolution agenda that pits rural against urban areas. Time and time again, the Labour government has shown they are not willing to listen to rural areas, but are quick to sell out rural Britain, at the first chance. As is typical, Labour's response to pressure is to level down some areas, serving only to create additional pressures elsewhere rather than acting to fix them. The pressure faced by rural healthcare is not something that will disappear soon. In the NHS long-term workforce plan, published under the previous government in 2023, it recognised the increased demand from an ageing population is not uniform in the UK. It estimated that in 2037, a third of people aged over 85 will be living in rural communities compared to just a quarter now. The government must act to address this trend. Madam Chair, I have been campaigning for a new medical centre, as was acknowledged before, in Knutsford, where doctors desperately need more space and modernised facilities to meet patients' needs that the current surgeries in Knutsford don't do, all Victorian buildings, and are not suitable for today. I have been pressing for this and wanting this for a long time now, and I have met with the Minister, and I thank her for that. And I would be grateful for an update on the progress of this practice in Knutsford. GP practices deliver community care, and their ability to deliver is reliant on the environment in which they serve the patients. We must have a funding formula that acknowledges the challenges of delivering healthcare in rural areas. And I would be grateful for the Minister to answer the following questions. Who is being consulted in this review? And will this include those with first-hand experience of delivering healthcare in rural settings, like my GPs in Tatton? What assurances can be provided that rurality will remain a factor in a new funding formula? And given the very specific challenges they face, will the Department commit to publishing an assessment of the impact on rural communities ahead of any change to the funding formula?
The question is that this House has considered GP funding in rural areas. Minister.
Thank you, Ms Loeb, and it's a pleasure to serve under your chairship this afternoon. And I thank the Right Honourable Member for Tatton for securing this debate and raising this critical issue, which I know is very important to many honourable members more broadly. And I am pleased to be here. I am here on behalf of my friend, the Minister for State for Care, who's obviously working hard on this issue. Ms Brewer, that this government has made primary care a pillar of NHS reform to make the left shift and put more healthcare into the community. And as we made clear in our 10-year plan, we specifically highlighted our commitment to people in rural and coastal areas because they have been left behind. As her friend from Chester South highlighted, the infrastructure is appalling in many places, and we do have some of the worst deprivation in some of these areas in the country. And I was pleased to visit Redruth last week in Cornwall to talk to a GP practice in Redruth about the deprivation they face and the work that they are doing. So we do understand that, and that's why we highlighted that in our 10-year plan. And over the last 18 months, we've taken a number of measures to increase funding, support our workforce and improve patient access so we can rebuild the front door to the NHS and create a neighbourhood health service. And it's important to remember, when we came into office 18 months ago, we found GP services in an appalling state, underfunded, understaffed and in crisis. First, we inherited an absurd state of affairs where patients couldn't book appointments while GPs couldn't find work. So we took immediate action to put GPs to work so patients could get the care they need. And we promised to recruit 1,000 more GPs through the additional roles reimbursement scheme. And we recruited not one, not two, but 3,000. And in the Right Honourable Lady's ICB area of Chester and Merseyside, that means 102 more GPs to the front line at the end of last year compared to when we took office. Secondly, for the first time in more than a decade, we've agreed a GP contract, which means more than £1 billion extra for general practices, bringing a total spend on the contract to £13.4 billion this financial year. That's the biggest cash increase in over a decade. And thirdly, the previous government left GP surgeries with leaky pipes, falling roofs and buckets catching rainwater across the country. So we are investing £102 million to fix GP surgeries this year. And over the next 4 years, we're committed to investing another £426 million on GP estates and refurbishing neighbourhood health centres. On top of that, ICBs will have £195 million every year to support strategic primary care investments with a focus on replacing crumbling infrastructure that many honourable members have raised here today. And I'm proud to say that we can now see some green shoots of recovery in primary care as, according to the ONS, patient satisfaction has gone from 60% to 73% since this government took office. It's a lot done. We absolutely recognise there's a lot more to do, especially as GPs become the cornerstone of our neighbourhood health services. And over the course of this Parliament, we'll train thousands more GPs. We've already made an additional 250 training places available this year, taking the total up to 4,250 places, with plans to expand this further. And on to specific points raised by the Right Honourable Lady. I'll start with Knutsford. As she said, we did meet about this last year. So on the medical centre, East Cheshire Trust are working on their outline business case, which they then need to submit to the ICB. The ICB then needs to be satisfied with submission, which would progress to a full business case, which would take some time to secure the necessary planning permissions, but they also need to look at how the clinical services work for both the general practice and the trust, how they'll be delivered, and obviously making sure that is value for taxpayers' money. And that lines up with the overall development, which we do want to see towards neighbourhood health services. We do expect ICBs, as I said to the Right Honourable Lady before and to many honourable members, we do expect ICBs to be collaborative and keep their local members of Parliament up to date and in the loop regarding the plans for those constituencies. But that is the situation at the moment. The Trust are working on the outline business case with the medical centre, and that's where that conversation needs to progress. With regards to the main subject of the debate with regards to the Cahill formula, and I must confess, Ms Newell, this is something that I've seen many years over my time working as a manager in the NHS as well. It is a difficult issue. It is one we're taking very seriously, particularly in regards to the issue of wider access in rural areas, because rural and remote areas do face specific pressures, whether that's challenges in recruitment, longer travel times, for example, or population fluctuations for various reasons, including in places tourism. They are specific pressures. And that's why the last Labour government introduced the formula in 2004. But we believe the formula is no longer fit for purpose today. A lot has happened in those 20 years, and the research underpinning the formula was done in the early 2000s, meaning that so-called workload coefficients were estimated based on data that may reflect clinical practice, such as patterns of home visits, as far back as the early 1990s. Clinical practice and population health have changed markedly since that time, and GP practices serving more deprived areas receive, on average, 9.8% less funding per needs-adjusted patient than those in less deprived communities. This is despite having greater health needs and significantly higher patient-to-GP ratios. So we are asking experts to help us design a formula that reflects patient need more accurately, working under the principle that funding for core services should be distributed equitably between patients across the country. Deprivation is a factor, but it's not the only factor. And let me be clear, this is not about taking GPs away from urban areas or robbing Peter to play Paul. It's about making sure that funding is fairly distributed. Now, the Right Honourable Lady rightly says the review is being conducted by the National Institute for Health and Care Research. The review team has already engaged with partners at the Royal College of GPs, the General Practice Committee of the BMA and the NHS Confederation, amongst others. And whilst I can't preempt the review, I would say to her that the point is to ensure that funding is targeted towards areas that need it most. That means considering a broad range of factors relevant to the delivery of primary care services, including difficulties delivering services, as she and others have outlined, in rural areas. And we expect the first phase of that to conclude in March. We'll then see if there's need to be further work to technically develop and model any proposed changes to the formula. Now, we will, of course, in response to one of her questions, we will, of course, look to understand the impact of any changes to the current formula on practices across the country ahead of implementation. And my honourable friend will update the House on the progress and outcomes of the review in the normal way. But lastly, can I just highlight, and I think many honourable members know this, but it's worth highlighting, that some 40 to 50% of GP practices' funding is currently not determined by this formula. The income into GP practices is based on a number of other areas as well, and also, obviously, we will be developing our neighbourhood health services in the future, so we need to take notice of all of those factors. I do want to just highlight about the issue she raised about analogue and digital. It is a key part of our 10-year plan. But as my honourable friend, the Minister for Public Health, said last week, wherever you live in our country, you deserve the same access to healthcare as everyone else. Wealth should not determine your health, and neither should your postcode. Now, I understand the point she and others have made has been made to me very often about infrastructure and access, particularly on digital. but there is huge potential to help us fight inequalities using digital based on geography. So, for example, the online services for GPs we launched in October. Patients can now contact GPs through online services to request an appointment or raise a non-urgent query in addition to telephone and in-person requests. It's tackling that 8 a.m. scramble that we committed to when we came into power, so patients no longer have to wait by their phone, waiting to call GPs at a time of day when many go to work or get their kids ready for school. And the Right Honourable Lady correctly says that rural communities largely have older populations. We want to be digital by default. Many older people are very digital, but human where it matters. That means that people in rural areas and elsewhere will still be able to use the phone if they want to, and they won't be waiting nearly as long because the other phone lines are being freed up. And I think we're seeing real progress in that area. Ms Lewell, when we came into government, the front door of the NHS was hanging off its hinges, but in these 18 short months, we are seeing the green shoots of recovery in general practice. We're seeing recovery and reform in primary care. Our plan for change is creating a neighbourhood health service that put GPs at its heart, so the NHS is there for everyone wherever they need it. We know that's not going to be easy. We want to work with them to develop that. But I hope today that we've set out how we're trying to get there. Yes, there is more investment, but there's also fundamental reform. And my honourable friend will be happy to keep in contact with members as we progress with this issue. Thank you.
The question is that this House has considered GP funding in rural areas. As many of that opinion say aye. Of the contrary, no. I think the ayes have it. Order, order. The sitting is suspended until 4:30.